Hello, welcome to this edition of the Mayo Continuing Education Cardiovascular Webinar Series. My name is Dr. Steve Amman. I'm one of the cardiologists at Mayo Clinic in Rochester, Minnesota, and I'm joined today by my colleague, Dr. Gabor Bagameri, who's one of our cardiovascular surgeons. And we're going to talk today about hypertrophic cardiomyopathy with a focus on the management of obstructive HCM and surgical aspects of that disease. Neither of us have relevant financial disclosures for this talk, and so we'll get right into the content for today. And I'm going to set some background before Gabor takes over and talks to you about some of the surgical perspectives of this condition. Here are the learning objectives we're going to cover today, and we'll take each of these in turn. But one of the things I always like to start with is making sure that we all have the same baseline information about HCM, and really these are the things I expect all of my patients who leave our clinic to understand about HCM. First of all, it's not that rare. About 1 in 500 people around the world has hypertrophic cardiomyopathy. The overall prognosis is good. Most people with HCM will live a normal number of years with a good quality of life and likely to die from non-cardiovascular disease. There are exceptions to that, and as you can see, there's a sudden cardiac death risk of just less than 1% per year. And so in many of our patient discussions, that's the bulk of our activities. That's not the focus of today's webinar series, however. This can be a familial condition, so patients need to be screened, and their family members, typically their first-degree relatives, need some form of screening. All the rest of our therapies, both medications and invasive therapies, are really designed to relieve symptoms, and we do encourage all of our patients to lead an active, healthy lifestyle that includes low to moderate intensity exercise as part of their lifestyle. So let's focus now on the pathophysiology of symptoms for patients with HCM. The thick heart muscle is stiffer than a normal thickness heart muscle, so almost every patient has some degree of diastolic dysfunction, which can cause increased left atrial pressure and decreased cardiac output, so patients can often have shortness of breath with effort or general fatigue from that standpoint. But today we're going to focus on the systolic phenomenon of obstruction. And we'll show some graphics of that coming up, but nearly 2/3 of patients have some form of obstructive disease. And this can lead to subendocardial ischemia through increased myocardial oxygen demand and decreased supply. It leads to variable degrees of mitral regurgitation and also can decrease forward cardiac output. All of these phenomena actually worsen the diastolic phenomenon as well. So this is why patients can be so symptomatic with effort. It also shows you why treating the obstruction is such an attractive therapy for patients who do have symptoms. This graphic really shows the basics of what happened. The hypertrophied septum that you can see here forces the blood flow to go around that septum and go across the mitral valve rather than parallel to it, and it pushes that mitral valve into the outflow tract and opens it up for posteriorly directed mitral regurgitation. We define patients of having outflow tract obstruction if we can demonstrate a gradient of at least 30 millimeters of mercury at rest, but we think it takes a gradient of at least 40 to 50 millimeters of mercury to cause substantial symptoms. The point there is if you have a patient who has class 3 level shortness of breath and you can only get a gradient of 30 on their echocardiogram, it means you need to look for other causes for their dyspnea. One of the other key points about the obstruction in HCM is that it's dynamic. It gets worse in states of increased contractility, decreased afterload, and decreased preload, which means patients at rest rarely have symptoms because their obstruction is minimized. It also means that the echo gradient that we get is probably the lowest their patient's gradient is going to be that day. It's higher when they stand up and walk out of the echo lab. But these loading conditions can be manipulated by functional maneuvers, such as making sure the patient is hydrated or using some of our baseline medications. That is the approach that we take in the HCM clinic. So that's where we're going to go now, is to talk about the standard medical management of patients who have symptoms with HCM. So the baseline of therapy for years has been beta blockers or the 2 non-dihydropyridine class calcium channel blockers, verapamil or diltiazem. These all decrease contractility, so decrease the tendency to outflow tract obstruction. They slow the heart rate down, which prolongs the diastolic filling period and so maximizes preload. Most patients can respond to these therapies reasonably well to achieve a good quality of life. Disopyramide is an antiarrhythmic drug that is also a negative inotropic agent, so it has been added to some of the other agents for some patients, and we'll talk about its success rate in an upcoming slide. It's also important to get patients off of therapies which might be harmful for their situation. So pure vasodilators decrease their afterload and make them more likely to have outflow tract obstruction. And similarly, high-dose diuretics or states of dehydration can drop their preload and increase their symptoms. Following these principles can be highly successful for most patients. This was a series of patients, this is years ago now, 1,500 consecutive patients referred to our HCM clinic. And remember, there's a referral bias there because patients were referred to us because they were failing therapy at home. But even in that case, 2/3 of our patients were treated successfully with simply adhering to those medication management principles. I also want to point out here on the bottom left-hand side of the slide that we judge success of medical therapy and surgical therapy for that matter based on how the patient feels. It's not so much about whether the gradient is lower after their therapy, it's can the patient do more than they could do before? Because that gradient changes from day to day, so whether you hit them on a good day or a bad day shouldn't be the determinant of whether the therapy is successful, is how the patient is feeling as a result of your therapies. Incorporating all these steps together resulted in the 2020 HCM management guidelines. This is a representation of what those say about management of obstructive HCM. Starting from the left, we make sure that we manage the rest of the patient as well and treat their comorbidities. Importantly, if a patient is asymptomatic, they do not require you to put them on therapy. You can simply follow them up on a regular basis. But if they do have symptoms, then we get them off of agents that might be making their symptoms worse, and we get them onto one of the standard first-line therapies and then assess them in the future. Again, if they're asymptomatic at that point, you do not need to make changes in their therapy. But if they remain symptomatic despite that first-line therapy, traditionally we've been faced with the options of enhanced pharmacologic therapy with disopyramide or sending them for septal reduction therapy, removing the obstruction, the mechanical problem that's underlying the symptoms, either through surgery or ablation. And there are subtle differences on why you might choose one over the other, and we'll talk about those coming up. Now, this has changed this year because there's a new medication that has come out for patients with HCM called mavacamten. It is called a cardiac myosin inhibitor. So at the baseline, for those of you who may not be aware that the muscle contraction at the cardiac sarcomere is when actin binds myosin and pulls that myosin in the power stroke of the contraction. In patients with hypertrophic cardiomyopathy, there is enhanced affinity for the actin and myosin. So it's in a more of a contractile state. It doesn't relax as well. It has increased energy utilization. The cardiac myosin inhibitors, mavacamten is the first in this class, actually relax some more of those actin-myosin bonds, so it trends that sarcomere back towards the more relaxed state rather than the hypercontractile state. And that was the basis of this first ever designed specifically for HCM patients medication. The main trial upon which the mavacamten was approved by the Food and Drug Administration was a 30-week randomized trial of patients to mavacamten versus standard therapy or placebo. You can see that 37% of mavacamten patients achieved a positive study endpoint as compared to only 17% of patients on placebo. In general, it dropped the left ventricular outflow tract obstruction by an average of 36 millimeters of mercury, but there was 11% of patients who dropped their EF to below normal ranges. When you look at that Explorer HCM trial, some of the phase 2 trials, and then a follow-up study called the Valor HCM trial that looked at more symptomatic patients, you can summarize the data on mavacamten as I have on the right side of this slide. About 37% of patients get a lot better, another 30% get some better, 30% have kind of neutral benefit, the 10% get worse, and the package insert reports about 25% of patients having some dizziness. So it's not like the majority of patients get a tremendous, benefit in this top category here. This issue here with the 11% who got worse also resulted in its approval coming with a complicated risk evaluation and management strategy, or REMS program. Patients have to be evaluated monthly when they're on the medication to make sure they haven't started new drugs that interfere with the mavacamten or vice versa. they have to have 7 echoes the first year that they're on the drug and 4 per year thereafter. The dose adjustments for the medication are also pre-specified with the FDA approval, so based on their echo gradients, symptom status, etc., the doses are automatically adjusted based on that. How does mavacamten compare to our other therapies? Well, I mentioned that we had used disopyramide as an advanced medical option before. Our best comparative data was a 3-year case series of patients on disopyramide. During that 3 years, 2/3 of patients did not have to escalate their therapy to invasive therapies. It had a similar hemodynamic benefit in terms of the gradient and a similar drug intolerance rate for disopyramide. The difference is this is a 3 times a day medication versus a 1 time a day medication and not specifically designed for HCM. Now, as I mentioned early on, what we're treating with medications are the functional things that exacerbate the outflow tract obstruction: contractility, preload, and afterload. But sometimes the hemodynamics or the anatomy are severe enough that you need a mechanical solution to this mechanical problem. And that's where the concept of septal reduction therapies have come in. And historically, we talk about septal reduction therapies to be surgical myectomy, which we've been doing here at Mayo Clinic since the late 1950s, and alcohol septal ablation, which has been around since the 1990s. They have the same baseline indications, that is drug refractory symptoms due to left ventricular outflow tract obstruction. And as I mentioned, there are pros and cons to each of these therapies. In general, myectomy gives you a more robust, custom solution for that patient with a bigger reduction in outflow tract gradient, lower need for pacemaker rates, lower reintervention rate, but it comes at a cost of a longer hospital stay, more pain during the sternotomy, and a longer recovery period than an ablation does. But in general, we tend to favor myectomy for patients who are vigorous enough and young enough to undergo cardiac surgery, and ablation as an alternative to that when it's not such a good option for patients. This is not a direct head-to-head comparison, but if you look at the differences between beta blockers, disopyramide, mavacamten, and the 2 septal reduction therapies, residual gradients after the therapy are different amongst those procedures. And again, a surgical approach by an experienced surgeon offers the most robust relief of outflow tract obstruction and symptoms for all of these patients. So I would summarize our approaches to patients with symptomatic LVOT obstruction to functional approaches or medication, which are lifelong and continuous therapies, or mechanical approaches, which can be one-time therapies, but require the need for expert operators or expert ablation operators. And maybe, Gabor, you and I can talk about what that means from a surgeon standpoint to be an expert in a particular procedure. So based on this new approval of mavacamten that occurred this year, this is kind of the way we see the outflow tract obstruction management going. If you continue to have symptoms after first-line therapy, then patients have the choice of disopyramide, mavacamten, or septal reduction therapy. You don't have to do these sequentially. A patient who gets to this point can reasonably choose amongst these 3 options through a shared decision-making process with their physician. So that's really where I think the state of this is going. We'll probably see some patients who use mavacamten even temporarily so that they can get the opportunity to see an experienced surgeon, or perhaps they just want to put off an operation until after a family event or something. We'll have other patients who will choose mavacamten as destination therapy as long as it works for them. And we'll see many patients who will still continue to have surgical relief of their outflow tract obstruction because they don't want to take lifelong medications. So at this point, Gabor, I've kind of set the stage for referring patients to you. I've got patients and I've presented them with the options for disopyramide, for mavacamten, for surgery or ablation. And so let's have you kind of walk through with the audience what it means from a surgeon's perspective to talk to a patient about hypertrophic cardiomyopathy and their symptoms.
Thank you, Steve. So the next couple of minutes, I'm going to talk about the surgical perspective, how to treat hypertrophic obstructive cardiomyopathy. And the remaining learning objectives are as follows. We are going to discuss the indication and surgical approaches, what we use to obstructive hypertrophic cardiomyopathy, and we're going to describe the management of the residual obstruction and mitral regurgitation in obstructive HCM. So septal myectomy generally reserved for patients with evidence of LVOT obstruction, as previously mentioned, and the gradient measuring 50 mm mercury either at rest or with provocation, and those symptoms are not relieved by medical therapy with impaired quality of life, usually NYH functional class 3 or 4 heart failure symptoms. Over the years, surgical myectomy has been a very successful operation for many of our patients. The patients either referred for surgery almost always have either failed medical treatment or developed side effects from the medication that limit them just as much as the symptoms from hypertrophic cardiomyopathy. It's very rare there is no benefit of surgical myectomy in adult patients with HCM who are asymptomatic. As it was previously alluded, the gradient and obstruction is very dynamic and sensitive to different loading, condition, and contractility. Subtle changes in this condition can lead to large variation on the LVOT gradients. Some HCM patients have minimal or no measurable gradient on the resting condition, but with provocation like Valsalva or squat to stand or graded exercise, they can develop clinically significant LVOT obstruction and can be documented by Doppler echocardiography. What's important is that dynamic LVOT obstruction is present in as many as 70% of the HCM patients who are symptomatic with dyspnea, angina, presyncope, or syncope. This already was discussed by Dr. Oman, and basically it's just a mechanism of obstruction and mitral regurgitation. In the majority of the cases of the HCM patient, the obstruction is due to the systolic anterior motion of the mitral leaflet because of the blood flow vectors dragging the anterior mitral leaflet into the LVOT and causing obstruction. From the obstruction, because of the anterior mitral leaflet moves to the LVOT, there is decreased coaptation between the anterior and the posterior mitral leaflet, and it leads to the classic posterior lateral directed mitral regurgitation jet. What's really important that the majority of the cases there is no underlying intrinsic structural mitral valve pathology, and treating the obstruction is going to resolve the SAM and the mitral regurgitation. There is a heterogeneous and variable morphology of the ventricular septum, LV outflow tract, and mitral valve in hypertrophic cardiomyopathy. Many different patterns and distribution of the LV wall thickening can be observed in HCM, with the subaortic wall the most common location for LVH. The different distribution of the left ventricular hypertrophy is the utmost importance to the surgeons when planning myectomy. So successful surgical management of the hypertrophic obstructive cardiomyopathy requires careful evaluation and understanding of the preoperative transthoracic and transesophageal echocardiogram. What we are looking for is at the septal thickness, the level of the obstruction, which is very important, the presence of any structural mitral valve disease, the distance of maximal thickness from the aortic valve annulus, the apical extent of the thickness, the location of the so-called endocardial contact friction lesion, and the presence of any anomalous papillary muscles. Most patients undergoing septomyectomy have a significant hypertrophy, with the septum measuring over 80 millimeter. But it's important to know there is a subset of patients who the septum measures less than 18 millimeter, and they still have significant obstruction and symptoms, and they do benefit from septal myectomy without any intervention on their mitral valve. So let's first discuss the most commonly performed, the transerotic extended septal myectomy, which is performed under cardiopulmonary bypass via sternotomy. We use full sternotomy, and we open up the aorta in an oblique fashion to gain access of the LVOT. So in addition to the routine intraoperal TEV, we use simultaneous measurement of the aortic and left ventricular pressure. In these two video inserts, you can see that we're inserting a needle, one next to the aortic cannula and one into the left ventricular outflow tract through the free wall of the right ventricle and the septum. Before going on cardiopulmonary bypass, we measure the resting gradient, and we are going to provoke a premature ventricular contraction and going to record the pressure measurement. And you can see the classic post-PVC Brockenborg sign, and there is a significant increase in the LVOT gradient, while the systolic blood pressure and the pulse pressure is decreasing. It's very important that after performing the myectomy, we're going to repeat this measurement. And as you can see, after eliciting post-PVC, there is no gradient across the LVOT. So in the next couple of slides, we are going to go through the basic steps of the septal myectomy. This is the surgeon view. The bottom is the surgeon where we are standing. The left of the screen, you can see is a patient head, and to the right is the patient left. And we are looking through the LVOT through the aortic valve. The first is we are going to identify the contact lesion, and we're going to start the myectomy just a little bit right to the nadir of the right coronary cusp and extending and counterclockwise towards the mitral valve. As a first bite, when we remove the first bite, it's important. It's not necessarily the deep, but the extent towards the apical area is what's really going to matter. What we now do more extensive septomyectomy that extends towards the apex of the heart, and we have learned over the years that this is the distal portion of the myectomy that's the most important in terms of relieving symptoms. The few patients who have had a second operation who have been referred to us after having an operation that was unsuccessful, we found that the myectomy that was not carried far enough into the ventricle, it is not the regrowth of the muscle, it is just an inadequate initial operation. So this is just a short video, a couple of minutes explaining we are going to do the aortotomy in oblique, looking at the aortic valve. You can see that the forceps, the white lesion is a contact lesion. We are usually using a 10 blade on a long handle. And as I mentioned earlier, we're starting the myectomy just right to the nadir of the right coronary cuffs. Yeah, just for note that the width of the blade is approximately 8 millimeters. So we're extending and going counterclockwise and parallel with the septum and taking the first bite and returning towards the mitral valve. Once we excise it, we're using a scissor to complete the excision. And we're going to remove this. In the insert, you can see the longitudinal view, what we're explaining. This is so-called the first cut. Again, what's really important is not necessarily the depth of the first incision, but how far we can extend it. Once this specimen is removed, we're going to examine on the operative field. And again, as I mentioned, it's usually we compare that the width of the first specimen should be approximately 8 millimeter width of the 10 millimeter blade. We can see the contact lesion. And once it was done, we're going for the second incision, and it's important that we use some adjunctive maneuvers to bring into the surgeon's view. As you can see, there is a sponge stick, and we're gently pushing on the anterior wall of the left ventricle and posterior diverting the septum to bring into the surgeon view the distal portion of the septum. We are going to go in a closer view. And as you can see, as we're gently pushing on the sponge stick, the distal portion of the septum comes into view. Some surgeon using the nerve hook to grab it and pull it into the view. It's important to know that we try to avoid the concomitant use of the sponge stick or the nerve stick because that there is a higher likelihood that we can tend the septum and cause iatrogenic ventricular septal injury. So this one, we're going back again. Again, we are not deepening the first incision. We're just going to lengthen. So meaning that we are going more towards the left ventricular apex and taking the second bite. As you can see, the bottom of the screen, the cardiotomy sucker is pulling and pushing out the mitral valve to protecting it and at the same time sucking out the blood from the left ventricle. Once the excision is done with the knife, we are going to grab it with the pituitary rongeur, pull it, and if it needed to be either cut or gently pulling until it's separating from the distal portion. So surgical approach to the mid or the distal ventricular septum can be achieved through the apical left ventricular ventriculotomy. It's called the transapical septal myectomy. There are certain situations like a complex long segment subaortic alveolar obstruction when there is a combined transaortic and transapical can be used to treat obstruction successfully. Sometimes when we are performing a transaortic myectomy, there is residual mid-cavitary obstruction without any evidence of systolic anterior motion, and it sometimes requires to perform a transapical. There are selected non-obstructive apical phenotype patient with refractory heart failure and abnormally small and distal LV cavity who also benefit from transapical myectomy. It's usually this picture, operative picture, so that the heart is lifted out of the pericardial cradle. We make a small incision, approximately 2 centimeters lateral to the left anterior descending artery. We open up the apex. It's very important to know there is certain abnormalities in the mitral valve, like the apically anterior displaced papillary muscles. So we're very careful that we don't inadvertently injure the papillary muscles. Once it's opened up, we are going to perform an anterolateral and posterolateral shaving of the septum. Occasionally, maybe we shave the papillary muscles. And once this was done, this was closed over a Teflon felt into 2 layers. So surgical myectomy has been a very successful operation for many patients, and extensive experience over more than 50 years has clearly demonstrated that the myectomy can abolish the LV outflow gradient, normalize LV pressures, hence improving functional class and quality of life in almost 90% of the patient. Furthermore, what's more important, patients who undergo septal myectomy have a very similar long-term survival to sex and age-matched general population, and recurrent outflow tract obstruction is extremely rare. However, surgical myectomy is underutilized, which is partly due to the perceived increased risk of the operation and the lack of surgeon with substantial experience who can do it. But in the hands of expert centers, the complication rates are very low, and the success is very high. As you can see, the mortality is less than 1%, with the clinical success is 95%. Recent data suggests that there is a strong volume outcome relationship, meaning that mortality is highest in the low volume centers and lowest in the high volume centers. So just let's talk about a little bit how to manage residual obstruction and the mitral regurgitation. Again, the residual mid-ventricular obstruction, usually when there is the myectomy then extended further down towards the apex. In this echocardiogram picture, you can see that there was a myectomy was performed, and even though there is no significant systolic anterior motion of the leaflet, but there is still persistent mid-ventricular obstruction because the myectomy was not carried further down. There are situations, as I mentioned, when you cannot safely reach this part of the area. That's when you're going to go for a transapical approach. So let's talk about the mitral regurgitation. The mitral regurgitation most commonly related to the systolic anterior motion of the mitral leaflet and the poor coaptation between the two leaflets, and that there is no intrinsic pathology in the mitral valve. Usually it's a posterior lateral directed jet. It's a positive, this is a good sensitivity, but the specificity is low. It could be that sometimes you have a central jet with a stem. If you have an anterior directed jet, you always have to be careful and look for whether any underlying mitral valve pathology. There are certain mitral valve abnormalities in hypertrophic cardiomyopathy, which we are going to discuss in the next slides. And it's possible, but usually it's less than 10% when there could be acquired structural mitral valve disease in hypertrophic cardiomyopathy. We treat it very similarly than primary valve pathology. Our preferred approach is that we perform a limited resection or plication of posterior leaflet and artificial cords for the unsupported anterior leaflet, and we routinely use flexible posterior band and are careful not to undersize it. So what are the abnormalities? I already mentioned it's very common. There is anterior and apical displacement of the papillary muscles. We usually don't relocate the papillary muscles. There is hypertrophy of the muscles. There are sometimes false cords and muscle bundles. There could be abnormal insertion in the papillary muscles. And so at the top of the screen, you can see when this abnormal papillary muscle inserting on the belly of the anterior mitral leaflet, you can safely excise it. When it inserts into the edge without the cords, you cannot excise, otherwise going to threaten the structural integrity of the mitral valve. So we found that it's really necessary to do something to the mitral valve without any non-structural mitral valve disease on preoperative imaging. Unnecessary intervention can result in a chance of injuring the valve, requiring valve replacement. And we would prefer to do a septal myectomy first, come off the bypass, assess the mitral valve with echocardiogram during surgery, and before addressing my mitral valve, if there is residual regurgitation, and we are sure that we eliminated all the obstruction. While mitral valve replacement eliminates the systolic anterior motion and associated MR, as well as the outflow tract gradient, the addition of the mitral valve replacement to myectomy increases hospital mortality tenfold and length of the hospitalization compared with patient undergoing isolated septal myectomy. Therefore, mitral valve replacement should not be the primary treatment option in obstructive HCM, and mitral valve repair is better than replacement. So what are the take-home messages? Adequate septal myectomy reliably and permanently relieves outflow obstruction with immediate symptomatic relief. It's important to remember that even after successful surgery, the patients still have hypertrophic cardiomyopathy, but hopefully they don't have obstruction anymore, and they need to be followed by their physician. Septal myectomy can be performed safely and most effectively in high-volume centers with surgery-related mortality less than 1% and durable success over 90%. Apical myectomy should be only performed by a few experienced myectomy surgeons in selected complex obstructive hypertrophic cardiomyopathy and in certain non-obstructive patients with refractory heart failure or abnormally small distal LV cavity as an alternative for transplant. And the most common cause for residual SEM MR and recurrent outflow tract obstruction is the inadequate myectomy. Thank you.
Thanks, Gabor. That was fabulous. For the audience, if you want to submit questions in the Q&A function on the Zoom feed, then we can take some of those questions now. And while we're waiting for any comments there, let me ask you what you talk to patients about in terms of complications of CV surgery and myectomy in particular. How do you talk about that with patients?
I think it's very important to be transparent with the patient. And in our experience, as I mentioned, the mortality is extremely low. Obviously, there is a misconception in the old historical data. They mentioned around 6 to 8% mortality. So the biggest complication, the biggest fear is obviously creating a iatrogenic VSD. If you're too shy, then you're not taking enough muscle and the patient won't have full symptomatic relief. So we usually estimate approximately 1% of mortality and less than 1% of chance causing iatrogenic VSD. The other important is the potential of the pacemaker. If the patient has certain conduction abnormalities, especially if the right bundle branch block, the pacemaker rate is significantly higher, can be between 20 and 30%, and we just have to be transparent upfront for the patient.
Yeah, those are important things that patients need to know. The other thing that's also really important is to set expectations for patients about what their recovery is going to be like, because there's a natural tendency to be afraid of an operation. But can you talk a little bit about what the in-hospital recovery is like for our patients?
I think most of us, nobody really wants to have open heart surgery, the fear of the sternotomy. And it's just very important to know that the sternotomy actually is very well tolerated. The average length of stay after the surgery is usually 4 to 5 days. Now, the first couple of days, obviously, as you mentioned in your slide, compared to the septomyectomy, there is a higher pain. But in 48, 72 hours, the pain is relatively well controlled. Most patients should be able to go home after the surgery. And the recovery, what I tell my patients, usually around 4 to 6 weeks, they should be back to close to 80% where they were before the surgery, and hopefully better because they have immediate symptomatic relief. And by 3 to 4 months, they should be back to 100% and hopefully way better functional status.
Yeah, that's right. And there's a question here that came in about the medications we use after myectomy. And typically we'll continue them on a beta blocker because it's hard to just stop a patient from that cold turkey because they'll have rebound tachycardia and maybe hypertension. But we'll get rid of things like disopyramide and those types of things. But it varies from patient to patient based on their heart rate and blood pressure a bit. But are there other routine or common medications you see some of your patients going on after surgery?
I think what's important, we try to avoid the polypharmacy. We try to decrease their medication. But as you mentioned, we continue certain medication. These patients usually have autonomic dysfunction after surgery. Their blood pressure regulation is changing. So we try to start with a lower dose, not usually necessarily put back on the home dose. And the routine DVT prophylaxis, apart from that, and pain medication, we don't really try to avoid other medication unless they have indication for blood thinner.
Right. Yeah, and the other thing that we do is I talk to my patients that usually when they get through that 8th week of recovery after the operation, if they've been on medications, we can see about weaning them off of some of those medications at that point. It's once they've been through that full recovery process. There's a question here from me about whether we use mavacamten for other types of HCM other than obstructives as first-line therapy. And the answer at this point is no, not yet. There are ongoing trials of using cardiac myosin inhibitors for non-obstructive HCM patients, but those are really still in clinical trial phase. And at this point, mavacamten isn't considered first-line therapy for obstructive or non-obstructive therapies. Another question here is about ventricular arrhythmias after septomyectomy. Can you talk about the early in-hospital? Do you see much VT or other ventricular arrhythmias for your patients after the myectomy?
We don't. There is no increased. I know there was a presumed with alcohol septal ablation might be increased, but I think the data shows that it's not really.
Yeah, and if we look at our data on patients who had indications for ICDs otherwise, who then went on and had myectomy, we see a lot lower rate of appropriate ICD discharge long-term over the next 5 to 10 years when they've had a myectomy. And to me, that's because we're just relieving stress on the ventricle, and it's much less likely to be electrically irritable at that point. So you and I both made points during our talks about the experience centers or expert surgeons. And there was discharge data that showed that the lowest tertial volume had the highest mortality rates with myectomy, and the highest tertial did better. But there's even a difference amongst the high tertial center versus a true HCM center. And you've been a surgeon who worked on complicated valve issues for a long time, and then have gotten more and more involved with the myectomy practice. And what does it mean, both your prior experience with valve issues, but in the HCM world, to really get that experience to be a true expert in doing this procedure?
I think it's a great question. The learning curve for myectomy, I think it can be quite challenging. And if I recall my own training, I didn't really have a significant exposure to the myectomy. So because of the view of looking through the aorta, it's a very limited visibility. So it's not an easy procedure to teach to resident or fellows. Now, with the help of the thoracoscope, you can see that video which I showed you. It was recorded with a thoracoscope. So actually, through the thoracoscope, holding the assistant, the rest of the team also can look at the procedure. What's important is that in theory, it sounds relatively simple, taking some muscle out of the septum, but the consequences can be dire. As I said, if you don't take enough, you cause iatrogenic VSD. If you take too much, if you don't take enough, then the patient not going to have resolution. In my own personal practice, I think you have to be very comfortable with the aortic root and the LVOT anatomy. And as I mentioned, even though there is no, the primary mitral leaflet pathology is relatively low, but you have to be comfortable with the mitral valve replacement. Here at the Mayo Clinic, we do a lot of redo surgeries involving the aortic root, so we can very comfortable in the surrounding anatomy and how to manage complication. It's also important that we have a very heavy adult congenital practice. And when you are operating on this congenital patient, sometimes they have a very narrow LVOT, they have a subaortic membrane, and you have to do certain procedures like the Kono procedures to enlarge it. And you became very familiar with the anatomy. But most importantly, I think it's very important, the appropriate mentorship, I think, and the supervised, graded supervision, that first you understand the pathophysiology. And I think for me it was very helpful actually shadowing you in the HCM clinic to understanding what the patients are asking, what are looking for the medical management, and what happens before we deciding for surgery.
Yeah, I think that is important. And then just the way, between Dr. Danielson and Dr. Schaff and Dr. Durrani, how the way that's been passed down is you actually worked side by side with them for a long time to get more familiar with this procedure, which has such a limited view.
And it was also that we co-scrub in cases, not just HCM, but complex congenital aortic cases. And you slowly pick up the tricks and how you can really be a master. But it takes a long time. And when you start, obviously you start with the more straightforward sigmoid shape, transerotic myectomy. And still when you're going into the decision-making about which patient is going to require transaortic and transapical at the same time, I think it's always good to get a second opinion and truly the multidisciplinary teamwork discussing the echo and then how to interpret the echo properly.
Yeah, and you had mentioned the importance of measuring and assessing the success of the myectomy in the operating room with direct pressure measurements. How often do you think that, on average, you and the Mayo team have to say, "Oh, we have to take out some more," because you're still seeing gradients at that point after the initial resections?
I think it depends on who do you ask. If you ask me, depending where you are in your learning curve, I definitely can recall that I went back because I was more cautious at the beginning. I err on the side of taking less. And it's not just the hemodynamic measurement, it's the correlation between the hemodynamic measurement and the simultaneously the TEE. And having the confidence that I know that my colleagues in cardiology, they can point out sometimes subtle findings which, it may like maybe it looks good at first glance, but maybe there is some evidence I didn't take enough. So for me, right now, it's probably around 10% when I have to still go back. But obviously, as you mature and getting more comfortable, it becomes less and less.
Yeah. One of the things that patients often ask me when they come to clinic is there a way to do this operation that doesn't involve the full sternotomy? And so what is a surgeon's viewpoint on that?
As I mentioned, nobody really wants sternotomy. It's how scary for the patient. Here at the Mayo Clinic, we consciously do full sternotomy. And again, the most important item, if you recall from that illustration and from the video, the second bite, when we are extending towards the apex, and when you do minimally invasive, you don't have access to the heart.
Yeah.
And it's very difficult to pull into the view. Now, I mentioned that some of the surgeons using hook, but when you're doing, already it's a limited incision, working limited incision with a limited view, it becomes extremely difficult. So we prefer full sternotomy, so we can use that, the gently moving the septum and bringing it to you, so we can really evaluate that we go as far as it's possible.
Yeah, that's an important point. The ability for you to manipulate the heart requires you to have enough exposure to do that. Yeah, that's very interesting. Again, we still have some opportunities for Q&A in the Zoom feed. If any of you have questions you want to ask us at this point. We didn't talk much about it, but you did open the conversation about using an apical approach for those who have kind of a distal kind of mid-ventricular obstruction. But we've also been using apical myectomies for patients who have non-obstructive HCM with massive hypertrophy. That to me feels scarier because, as a surgeon, like you said, you're very familiar with the aortic root because you've done so many aortic valve replacements, and you know the mitral valve through all your mitral valve repairs, and so you kind of know the anatomy up there by the base of the heart. But just to kind of go in blindly to the LV cavity, talk to me about how that feels as you're getting used to doing those procedures.
I think I agree with you. Even for me, who's doing open heart surgery every day, the idea, especially when it's not necessarily for obstructive and non-obstructive, it's kind of scary, and how you judge. Yeah, in a certain way, there is no objective landmarks we are going by. And I think that's the ultimate culmination when you can really, that you can say that you're an experienced Takehome surgeon when you can perform. It's learning the cases, scrubbing, like with a senior surgeon. I think for me, it's definitely with scrubbing with Dr. Durrani and Dr. Shev every opportunity. And you don't always have to be there scrubbing. You can just looking from the outside. But that part is surely a little bit of judgment when it comes with experience. I think all I can tell you that it's not the easiest to start with.
Yeah. Yeah, well, I mean, I think that one of the beauties of our program here is the depth of the team we have. So, with Doctors Durrani and Schaff and yourself, and then with the medical team, we do function as a team. And so, like Dr. Bagamary said, he came and followed us in the medical HCM clinic for a while so he could understand the things that we're talking to patients about and seeing the patients that don't qualify or don't need an operation. And similarly, we're having some of our new staff members that are coming into our HCM clinic spend some time with the surgeon so they understand what the surgical care is like after the operation. But having that team that discusses cases openly, you're never on an island having to approach each of these patients, I think is one of the keys to success for the comprehensive HCM centers around there.
I just wanted to reiterate, and I think you already mentioned, but for me, I have been here for 5 years at the Mayo Clinic, but one of the best experience that you're never alone here in 24/7. So now it doesn't matter when you are doing a case, you can always reach out to somebody, and having a cardiologist, an anesthesiologist, or critical care physician, and helping you with the decision making. And that's, I think it's in the patient's best interest.
Yeah, I think that's perfect, and I think that's a great way to wrap up this discussion. So I want to thank you for taking the time to talk to me today. I want to thank the audience for joining us today, and hope you found this interesting and helpful for your practice. And we're always willing to answer your questions or help you take care of your patients with hypertrophic cardiomyopathy. Thank you.
Thank you.